Better?
Yeah.
Yeah, it's fine. It's fine.
Okay.
Fine.
So I'll keep it a little away then.
Distance, yes.
So we can all mute our mics when we are not speaking, and that might improve the audio quality. The admin, I hope, will be muting all the delegates' mics, right?
Yes, yes, Sanjay. All the others other than the speakers will be muted.
Right, sure. Right. Thanks, Keshav. Professor Abrams, Keshav is our honorary secretary of the Urological Society of India. So Keshav Murthy is in Bangalore. Keshav, hi.
Hello, sir.
I think it's too many pictures on it.
You
can raise your hand, Keshav, I think.
Hello.
So we'll start off straight with Keshav. I think you will take charge of this, isn't it, right? So 4 minutes to go.
Yeah.
I thought, hey, how is Bangladesh? It's in lockdown, I heard.
Good afternoon, sir.
Good afternoon.
Good afternoon.
Malik sir, Keshav sir, how are you?
I'm fine, Tawhid.
Thank you very much. Thank you very much. I got all your WhatsApp messages, and I circulate all to our members. I think so many will join.
Tawhid, this is a good moment to tell you, in case you have some young colleagues less than 5 years into their practice who are interested in the ICS, just let me know. Remember, I had mailed you.
Yeah.
And if there is somebody, we can try and get them a free membership for the first year at least.
Okay, sure.
Right.
I'll let you know.
Sure.
Abu, তুমি এটা করে দাও তো তোমার
Sir, how is Hyderabad from a COVID standpoint?
We have a fantastic policy. We don't test, so we don't know what it is. Whenever there is an arrhythmia, we switch off the monitor, so we don't see the arrhythmia at all.
No, it's bad.
Bad.
Yeah. Bad. I mean, last week, in a matter of 36 hours, I personally had 5 positive patients.
Yes, of course. Every day we send around 20 patients, 20 COVID samples, and we get 3 to 5 getting positive now.
And 6 months, we had not even 1 positivity. For 6 continuous months, not a single patient came positive. And then 36 hours, I had 5 patients positive. Keshav, 2 minutes to go.
Yeah, every day we have 20% of the list getting cancelled because they turned positive.
Yeah.
Hospitals are full, no beds, lot of recommendations for beds.
Yeah.
Same with Delhi, I think.
It's all over the country, the same story.
Delhi deteriorated a lot in the last 1 week.
Everywhere it is same.
The peak in Delhi was 9,000 cases per day, and today we have approached the same peak again.
Could have had Boris Johnson as your Prime Minister.
Well, he's ending well.
Boris Johnson has been a disaster in every respect.
He's
vaccinated. Except for vaccination.
I think it's 4.
Vaccination may save him.
Good evening, everybody. Good evening, everybody. Welcome to this webinar from the Female and the Functional Urology subsection of the Urological Society of India. We have a very important topic today, Nocturia, Basics to Advanced New Concepts. And it's a pleasure to have Professor Paul Abrams from UK, who will be our international faculty, and the national faculty also will be participating in this. And Sanjay Sinha will be the convener, but It is moderated by Pawan Vasudeva, as Sanjay Sinha is in Boston now, right now. So I would now invite the President of the Urological Society of India, Dr. Mallikarjuna, to give his opening remarks.
Thank you, Keshav, and thank you, Sanjay. A nice program being planned for today, and it's a welcome to Dr. Abrams once again to the USI webinars. In multiple occasions he has been there. Father of modern urodynamics, I would say. Abrams is synonymous with urodynamics and functional urology of late. And thank you very much, sir, for accepting our invite. And I think it will be a great learning session for all of us in the USA members. And Nocturia being the great topic, which possibly under-discussed in majority of the occasions. Thanks, Sanjay, for taking this up. And Pawan Vasudeva will do a good job on this. All the best for a good program in the next 2 hours.
I would now invite Professor Rajiv Sood, who is the chairman of the Indian School of Urology, to give his opening remarks.
Thank you, Dr. Keshav. Welcome, Dr. Pral Abraham. We have heard you so many times, and every time we learn from your deliberations. And today it is the discussion and the line which is there, which you have given, that basics, not only basics to advanced, but also most bothersome of LUTs, that is Nocturia. So that is the punchline, and we are going to discuss that. And Dr. Sanjay Sinha and Dr. Pawan Vasudeva, who are the members of our, who are running our very successfully functional and female urology, that we are looking forward. Many programs have been done. Guidelines are also coming on various aspects of functional and female urology, and this webinar will pave way for getting more insights into the topic and what is latest. So I welcome all the audience, all the delegates, and all the faculty for the success of this program. Thank you. Back to Dr. Keshav, please.
Thank you, Professor Sood. I would now invite Dr. Sanjay Sinha to give his opening remarks.
Well, welcome to everybody, all of you, whichever part of the world you're tuning in from. All our programs, as you know, are accessible for free from across the globe. This is another program from the Functional and Female Urology subsection of the Urological Society of India. And we thought we would discuss today the approach to Nocturia from basics to the advanced new concepts. And there were certain important reasons why we felt this subject needed to be discussed. We know that Nocturia is common. About 1/3 of adults will report getting up in the night at least 2 times to pass urine. And at least 6% report that they have moderately bothersome nocturia. So it's fairly common, often bothersome, and this is regardless of gender. It is more bothersome typically than daytime lower tract symptoms, and it has a significant impact on the health-related quality of life, possibly by a sleep disruption mechanism. More importantly, there's some evidence to suggest that nocturia might be associated with an increased mortality in individuals. So for all these reasons, and because nocturia is not well discussed in either the curriculum or in our regular meetings, we felt that nocturia needed to be discussed in detail in a separate session of its own. It deserved that kind of a discussion. We have with us today some of the best stalwarts in the field to discuss this. Professor Paul Abrams is not new to any of you. He's honorary professor at the University of Bristol, has authored more than 400 papers. He introduced the terms lower tract symptoms and overactive bladder, has had a Lifetime Achievement Award from the ICS and SUFU, an SIU Distinguished Career Medal, and the Willy Gregoire Medal from the EAU. Welcome, Professor Abrams, to the program.
Thank you.
We have Professor Ganesh Gopal Krishnan, former professor of urology from CMC Vellore. He's a consultant urologist at the Veda Nayagam Hospital in Coimbatore, and is now a magnet for all the residents who want to learn as well as get their certification, because he runs a very good teaching program from this hospital. He's a legendary teacher, has several generations of students, and has been awarded with the B.C. Roy Award, which is the highest award for teaching in the medical field in India. He's a former president of the Urological Society of India. Dr. Ganesh might be a little late in joining us for this program, but he will join us a little later hopefully by the time the panel discussion starts. Dr. Anita Patel, who's a senior consultant in Mumbai and is also on the teaching faculty for the Nadiad Center, and is a regular part of all our programs on functional and female urology. Welcome, Dr. Anita, to the program. Dr. Rishi Nair, he's Associate Professor of Urology from All India Institute of Medical Sciences, New Delhi. And Dr. Vijay Madhuri, Associate Professor of Urology from All India Institute of Medical Sciences, Jodhpur. Welcome, Dr. Rishi, and welcome, Dr. Vijay, to the program.
Thank you, sir.
The program will be moderated by Professor Pavan Vasudeva from VM Medical College and Safdarjung Hospital. He's a member of the Functional Urology Society subsection, Functional and Female Urology subsection, as well as a member of the Neurourology Promotion Committee of the ICS with several publications in the field. We have a resident representative in the form of Dr. Sujit Jose. Sujit, welcome to the program. He's from Government Medical College, Kozhikode, Kerala, a third-year resident. He's given his research inputs, and I hope that he will also be having some questions for our faculty. And I'm Dr. Sanjay Sinha. With these few words, let me tell the plan for the day. We have a lecture for half an hour by Professor Abrams on the etiology and evaluation of patients with nocturia. We would not be taking questions at this point at the end of the lecture. All the questions and discussions would be a part of the case discussion session, which will be moderated by Professor Pavan Vasudeva with research inputs, as I said, from Sujit. The faculty for this is all the faculty who are today part of the program will be a faculty for this panel discussion and issue-based discussion. It will be followed by a short open house session with the faculty for 10 minutes where all the viewers can key in their questions. In any case, all through the program, I would encourage our viewers and delegates to send in their questions when we'll try our best to include these questions, queries, doubts, comments into the program at some point or the other through this panel discussion or during the open house session. And finally, we'll have a summing up by Professor Vasudeva and myself. With this, I now hand over the session. I call Professor Paul Abrams, I call on Professor Paul Abrams to make his initial 30-minute lecture on the etiology and evaluation of patients with nocturia. Welcome, Professor Paul Abrams, to the session.
Well, thank you very much indeed for your introduction and, of course, for your invitation. But I should say straight away, I would much rather be in India. It's very bright here, but it's cold, and I would love to be warm. Still, that has to wait. But it looks like a very interesting session, and I'm looking forward to the discussion. So tomorrow I will go to the beach, but it will still be cold at the beach, not like the beautiful beaches at Manipal. So we're going to talk about nocturia, and remembering that nocturia is just one of the storage symptoms that are split up into storage symptoms, voiding symptoms, and post-micturition symptoms. We have a very clear definition, the complaint that the individual has to wake one or more times to void, and this was quantified in the updated ICS document of 2019, the number of times an individual passes urine during their main sleep period from the time they've fallen asleep up to the time that they intended to get out of bed. Now, as Professor Sinha has said, nocturia is extremely common, and I'm quoting now from the EAU guidelines. You may not realize, but really in the last couple of days, both the EAU male LUTS guidelines and the EUA female LUTS guidelines have come online. So you can access those. And so this is taken from it, and you can see that, of course, nocturia varies with age, and I'll come on to that in more detail. It's common in the US, in African Americans, in 5,000 US adults between 30 and 79, 28% had nocturia, correlated to obesity, cardiac disease, type 2 diabetes, and the use of diuretics. We also need to remember that Nocturia is dangerous and is in fact increased by a 30%, associated with a 30% increase in risk of death. So if we look at the prevalence, this is relatively old, but I don't think there's been such a comprehensive one since then. And you'll see that there's very little difference in the percentages here, age 20 to 40 in men and women. In the various studies, around 25% in men, in women, 20 to 40, around 30%. Changes a little bit with age when the males go up a bit and the women have relatively less, but they've all increased, as you can see, with age. And you can see this quite nicely graphically. So at the top here in red is getting up once at night, and at the bottom here is getting up 4 times at night. So going from the age of 20, surprisingly, about 30% of women and about 20% of men get up once at night, even at the age of 20. By the time you get to 80, basically everybody gets up at night. So Nocturia sort of becomes normal. And I found as I and my friends get older, we have become more and more interested in Nocturia, and in particular, how to avoid getting out of bed at night to pass urine. So here again, we can see from the EPIC study, which is a very large study of 20,000 adults in Europe and Canada, that there's very little difference between women in red and men in blue. And you can see getting up at night again, if you're 40, then both men and women, about 30 to 40% get up once at night, but by the time they get over 60, it's up to 70% get up at night once. Getting up twice, again, very similar between men and women. And of course, we used to think about Nocturia as being a male disease because in the good old days, 30, 40 years ago, if you were a man and you complained of Nocturia and you were 75, some nice urologist would take your prostate out. And we'll discuss what might have happened to all those people. It's true throughout the world. This is a study of Korean men living in the community, living at home, and you can see from 40 to 78 years old, 2/3 got up at least once. Only 1/3 didn't get up, and 20% were getting up 2 or more times. And of course, LUTS and Nocturia increase with age. I think the other perspective we need to take into account is that Nocturia doesn't usually come on its own. It usually comes, like all the other LUTs, as a mixture of storage and voiding symptoms. So we're immediately thinking, in a man or a woman who has Nocturia, do they actually have a second disorder of their lower urinary tract that's also causing their LUTs? I want to also say that, of course, we're going to see more than one condition in the same patient. This is overactive bladder, again, in a community setting, men and women, men in red, women in green. And you can see that they're very similar. OAB is very similar in prevalence to men and women. Why do urologists believe that OAB is due to the prostate in men? If it is, what's it due to in women? The point I'm making that both Nocturia and OAB are age-related, very similar in men and women, and probably nothing to do with the prostate. Can't be in women, of course. In men, there's a rapid increase in gland enlargement through the middle years to the later years, but the minority of men have prostatic obstruction. But again, it's a common cause of people being referred up. Many of them have Nocturia, and we have to sort out the responsibility of prostatic obstruction for creating symptoms, including Nocturia, as well as other causes for Nocturia. Now, the reason we fuss about Nocturia, particularly as we get older, is because of its effect on sleep. We have reduced sleep efficiency, and this causes problems with productivity in all senses of the word, around the house, working outside the home, your professional life. It affects your quality of life if you feel tired and you don't feel like doing anything because you've had a bad night's sleep. And then more seriously, it's associated with increased falls and fractures, and as I've already said, associated with mortality and morbidity. Now, there are questionnaires specifically for Nocturia and quality of life, and there is the ICIQ NQOL, which is a fully validated questionnaire, 13 items with 2 domains, one on sleep and energy and one on bother, can be used for males and females, and there are numerous translations. The key factor about sleep is the first few hours, and Don Blywise, who's a sleep expert, he identified the first 2 to 4 hours are vital. And if your sleep is not good in the first 2 to 4 hours, then your sleep quality is poor, and this leads to daytime dysfunction and tiredness. Why the first 2 to 4 hours? Well, that's because slow wave sleep occurs early in the night, and it's slow wave sleep that resets our body mechanisms. And there's a clear role for the need of this sleep in managing glucose homeostasis, and therefore poor sleep quality may be a contributor to increased risk from type 2 diabetes. Reduced sleep duration, the first 4 hours, is also associated with obesity, and we'll come on to that. And there's also an implication for the immune system. So a good immune system does depend on you having a decent night's sleep, and in particular, those first few hours. So it's pretty obvious, isn't it, that as the number of voids increase, then your quality of life will decrease. And you can see once you get up to getting up 4 or 5 times at night, then you have very poor quality of sleep compared with just getting up once or twice. But once or twice for some patients is still very bothersome. And one of the interesting things about talking to patients is that a chap will come in and say, I get up 3 times a night. You think, God, if that was me, I'd be exhausted. But you ask them, the chap says, oh, no, actually, I don't find any problem getting back to sleep. And if I need to sleep on in the morning, I can because I'm retired. But other people, just getting up once, they find they cannot get back to sleep. So never underestimate Nocturia ×1. It can be very bothersome to some people. As I've said, falls are certainly increased in patients with Nocturia, and there's about a 40% increased risk of falls. And the risk increases with the number of times the person has to get up. Again, that's pretty obvious. It's dark, the person may not be properly awake, etc. And fractures, getting up 2 or more times a night is an age-independent risk factor for hip fractures. And in the elderly, there's an increase of at least double in getting fractures if you have Nocturia 2 or more times. So it's a very serious condition. It costs a lot for the individual. It costs a lot for society. If we think about etiology, then of course, there are the urological causes. Benign prostatic obstruction and detrusor underactivity as voiding abnormalities can both reduce the bladder capacity because of a post-void residual and cause Nocturia. Detrusor underactivity can give urgency, and if the patient wakes and has urgency, then they will have to get up. Reduced bladder capacity in the true sense of the word really, I think, is rather uncommon. And then, of course, there's a host of non-urological causes for Nocturia, amongst which nocturnal polyuria is very important. So what does the EAU say in terms of diagnosis? Well, it says you must assess the severity and bother of each individual lower urinary tract symptoms. And for us, of course, we're talking about Nocturia. A validated bladder diary is mandatory. Look at the individual's behavioral factors that might affect fluid balance and sleep. Take a proper history and ask what drugs they're on. So if they're taking a diuretic at 10 o'clock of night, quite clearly they're going to be getting up a lot at night. And so that's easy to fix. You tell them to take it earlier in the day. Look at relevant comorbidities, and that would include renal failure, diabetes, which is not properly controlled, cardiac failure, which is not properly controlled, and obstructive sleep apnea that we'll come on to. So that is one of the sleep disorders, which again need careful thought. So a questionnaire that asks about bother is very important. So this is the ICIQ Female Lower Urinary Tract Symptom Questionnaire. And you can see that this asks the question, during the night, how many times do you have to get up to urinate on average? None, through to 4 or more. And then very importantly, the great advantage of this questionnaire for nocturia and all other lower urinary tract symptoms like urgency, etc., is how much does, in this case, nocturia bother you? From 0, not at all, up to 10. And bother is, of course, a very big issue, because if the patient is not bothered by their nocturia and you advocate a course of treatments, then the patient probably won't take them because they're not bothered. But most important, of course, is the bladder diary, and the ICIQ bladder diary, which I know Professor Sinha is working on, a Hindi translation. It's only available to you at the moment, unfortunately, in English, is the only validated one. It looks complicated, but this has been worked out with patients. And for nocturia and here for OAB, very important, from the OAB point of view, you've got a bladder sensation scale. So from 6 in the morning right through to 5 the following morning, you ask the patient to record the amount they drink and what they drink, tea, coffee, whatever, the urine output, their bladder sensation, that applies to the scale here, and if they're incontinent, how many pads do they use? So the bladder diary from the nocturia point of view gives you a lot of it, very important, I would say vital information. Of course, you get the nocturnal urine volume, and that's the total volume of urine that's produced during the night. So it includes the first void in the morning, because obviously that urine is produced during the night, and you do not include the last void when they go to bed, because that's urine produced during the day. You find the maximum voided volume, and you find the nocturia polyuria index. In other words, the percentage of urine that is produced during the night. So here is 2 days of the 3-day diary. You can see the volumes down here, what they have drank: water, juice, coffee, water, juice, the volumes they voided, and then the bladder sensation. Bladder sensation is all normal. So the person, this man in this case, does not have urgency, and therefore he does not have overactive bladder. But what you can see is that he gets up 3 times, 4 times at night, and then voids again. So how do we use this information? Well, we divide it into day and night. So he got up here and he voided twice in quick succession. That is urine produced in the night, the previous night. So we disregard that. This is the daytime production. Here is when he went to bed. And then in the black box is the urine that's produced at night. 1, 2, 3, 4 voids. So he is producing 700 mLs of urine during the day, and during the 8 hours of sleep, he's producing 1,280. Clearly very abnormal. If you switch them around the other way, that wouldn't be so bad. But this man clearly has nocturnal polyuria as the cause of his nocturia. So what about classification of nocturia? Well, firstly, it can be in a patient who has 24-hour polyuria. So throughout daytime and nighttime, they're producing too much urine, and it could be that they just drink a lot. And there are such patients who drink. There are patients who drink a lot when they wake up. Each time they wake up, they'll drink half a liter of fluid. I mean, it sounds crazy, but people do it. Often it could be something like diabetes mellitus, but very rarely do we see diabetes insipidus, but of course it could be that. The abnormality you really can diagnose off a bladder diary is nocturnal polyuria. And this varies with age in terms of its normal limits. So if you're a younger person, then if it's more than 20% of the 24-hour urine, then you can be said to have nocturnal polyuria. That's relatively unusual, but what we see very commonly is nocturnal polyuria in those over 65, and that's defined as producing more than 35% of your 24-hour urine in the night time. As the EA used this term, diminished bladder capacity, I think it's actually quite a bad term because these patients don't really have a diminished bladder capacity. And as I'll say in the next slide, what we should call it is diminished voided volumes. And then last, there's nocturia secondary to sleep disorders. So as I say, I don't think diminished bladder capacity is a very helpful term because it's confusing. And what we're really saying is that these patients have reduced voided volumes at night and often during the day. And this is seen, of course, in the common conditions of overactive bladder, bladder outlet obstruction, and detrusor underactivity. Of course, in overactive bladder, that's due to abnormal bladder sensation caused by their involuntary detrusor contractions giving urgency. But if you think about it, what can be the only cause whereby men, particularly with BOO, because they have prostatic obstruction, and men and women get nocturia due to these conditions? Well, I think you would agree it can only be if they have poor bladder emptying, and therefore a residual urine does not allow them to pass normal volumes of urine, and hence it causes low voided volumes. So as I said, nocturia with small voided volumes without a residual urine due to a true small bladder is actually relatively unusual. In terms of etiology then, in both men and in women, we need to discriminate when nocturia is a lower urinary tract symptom. And the word nocturia really confuses in a way because we don't instinctively make that differentiation between LUTS when it is due to a lower urinary tract dysfunction, and I've mentioned these already, OAB, chronic pelvic pain would be another one, obstruction and detrusor underactivity. We don't distinguish that from when nocturia is not a LUTS. If somebody drinks a lot, it's not because of a lower urinary tract dysfunction. And so we should discriminate and say, well, this is nocturia, but not of, it's not a LUTS and not due to lower urinary tract dysfunction. So it may be behavioral, as I've said. Some people are undoubted to drink a lot. It may be tea, coffee, it may be Coke, Pepsi, or just water. Do they have 24-hour polyuria? And that's defined as 40 ml per kilogram over a 24-hour period. So roughly speaking, about 3 liters for a 70 kilogram person. Is it due to nocturia, nocturnal polyuria? We've already said 20% is the threshold for the young and 33% the threshold for the older people. Is it due to a sleep disturbance or is it due to systemic causes? But remembering, as I've already said, that overactive bladder, prostatic obstruction, and nocturnal polyuria increase with age. So we must not be surprised if we need to treat more than one cause for the person's nocturia. So there are, of course, conditions which impair physiological fluid balance that influence the levels of free water, salt, solutes, and plasma osmotic pressure. And that brings in abnormalities of endocrine regulation, for example, antidiuretic hormone, ANP, cardiovascular and autonomic problems, renal problems, neurological problems, for example, abnormalities from the pineal gland or renal innervation. So in any nocturia patient, the urologist has a relatively difficult task because she or he must review the likely mechanisms and instigate review by appropriate specialists. For example, if the person has sleep apnea, then a respiratory physician may be necessary. So if you're going to look after nocturia, you need to know which medical expert you're going to send the patient to if it doesn't have a clear causative link with lower urinary tract dysfunction. And we should not be treating nocturia unless we go through this thought process. Is nocturia actually a real LUTS in this man's case or this woman's case, or is it a non-lower urinary tract condition? Now, if we think about the number of people with nocturia, then it's really extensive. And in terms of those patients with nocturia, then it's the majority of patients have nocturnal polyuria, where the kidneys and the other mechanisms I've mentioned, rather than the bladder, are the key role in producing their nocturia. Now, the other conditions which we can treat, or rather our colleagues can treat with us, are obstructive sleep apnea, congestive cardiac failure, poorly controlled diabetes, and altering the patient's medication. So we must remember to refer to other clinicians for many of these conditions. But I am well aware in my own personal life that peripheral edema is normal. So I would give the example of young people who go from India to America and they sit in the economy class. And if you ask them the question, and I always do when I come to India, give a teaching course, what happens if you take your shoes off at the beginning of the flight? Is there any problem getting getting them back on at the end of the flight? Everybody puts their hands up. So even young people get peripheral edema. If I spend now in my early 70s, if I spend the whole day in the office and take no exercise, I will be up at 2 or 3 in the morning to pass urine because I have had peripheral edema. This is normal. So I have learned that I must take regular exercise. It gets rid of my peripheral edema, which is barely clinically detectable, but also it's making me fit. So I'm going to come in the latter part of my talk to think about us being holistic in our management of nocturia. So causes of nocturnal polyuria are obviously, if you go to the pub, as a lot of people used to do before COVID in Britain, and you have 5 pints of beer in the evening between 7 and 11 o'clock, you're going to get up at night and you're going to have nocturnal polyuria. So adjusting people's food and fluid intake is very important. Peripheral edema, as I've said, due to relative inactivity, and as we get old, we are relatively inactive compared to 20 or 30 years ago. If you've got reduced ADH production, that may be a cause. And of course, if you've got heart failure, then you may be in problems, and that requires serious attention. And we'll come to obstructive sleep apnea now. Now, this is commoner than we realize. If you look at sleep abnormalities, insomnia is supposed to occur in 10 to 20%. Snoring, sadly, men snore more than women. This is true, but women also snore. 20 to 40% of men snore. Men and women get obstructive sleep apnea syndrome, 4 to 8% in the whole community. So it's not a rare condition, but it's poorly recognized. It's more common in men and more common in men who are fat. Restless leg syndrome is another problem. So this is our typical phenotype. Now, these are rather old now, but this is John Prescott, who was Tony Blair's deputy prime minister. And this is a character from the very well, actually, Sanjay, as you're in Boston, this is from Cheers, which was a very funny sitcom from 20 years ago. This is Norm, and he used to go to a bar in Boston. So this is the typical phenotype of a person that gets obstructive sleep apnea. They look like they've got no neck, and it's very thick. And of course, in these people, here's the tongue, here's the pharynx. If you've also got a fat neck, this increases the pressure on the upper airways. And what happens in obstructive sleep apnea, when the person is on their back, the tongue falls back, the palate falls back, and the upper airway becomes relatively obstructed. And you may well know that continuous positive airway pressure therapy is extremely effective. And you wear this mask and this solves the problem. And if you've got nocturia, it actually is the best treatment for nocturia. Now, what is again something that most people don't realize is that this is actually normal. We all have episodes of apnea during the night, but it should be mild, they should be short. And as they get longer episodes and more frequent, then the severity increases and it becomes dangerous. Now, picking it up from the man is very difficult. The person to ask is the wife. And if you can imagine sleeping next to a person who stops breathing, sometimes for up to a minute, makes dreadful noises and snores very loudly. That's very upsetting, and many of the women will go and sleep in another room. So the women can often diagnose it, but the men, of course, are asleep. Well, at least they're partially asleep, so they don't realize it. This is a dangerous condition and needs to have a referral to a sleep lab, usually run by respiratory physiologists. So how good are we at treating? How good as urologists are we at treating nocturia? Well, as I said, in the good old days, if you complained of nocturia, you got your prostate removed. And this is now getting on this paper. It's 18 years old from Japan, and it compares 165 men receiving tamsulosin and 138 men having a TURP, and looking at the effect on symptoms. And you can see that, yes, it did reduce the episodes of symptoms, but not in a very high proportion of the men who had the symptoms. And if we look at that in more detail, this is the same study. If we look at, these are the symptoms of the IPSS, you will recognize them all with nocturia at the bottom. And these are the percentage of patients who responded for each symptom. And you can see the best response, as you might hope, is for a weak stream, then the feeling of incomplete emptying, and look how badly nocturia does with respect to the others. And this is, of course, because nocturia was not due to prostatic obstruction, and it was probably due to nocturnal polyuria. And here you can see patients who are unresponsive to alpha blocker therapy. 85% of men with nocturia who were unresponsive had nocturnal polyuria as the reason. So if we don't diagnose nocturnal polyuria, we're wasting lots of people's time with respect to alpha blockers in this example for their nocturia, but of course it won't work. So I'm saying that we need to have more of a holistic approach to nocturia. And holistic approach means that characterize the treatment on the whole person, not just on the lower urinary tract. Take into account mental, anxiety, for example, and social factors, going to the pub and drinking a lot, rather than just the symptoms of a disease. So nocturia is associated with obstruction, but of course you can't assume that in the individual person, obstruction is the cause of their nocturia. In women, it's exactly the same. So these are patients being treated for overactive bladder with a placebo, randomized controlled trial, and 2 doses of solifenazine. This is the group, they all had bladder diaries, so this group were known not to have nocturnal polyuria. And you can see the reduction in the number of episodes of nocturia is actually rather modest, even if they don't have nocturnal polyuria. But you see, if they do have nocturnal polyuria, then the reduction is worse. Now, what have we got to offer? And in terms of thinking holistically, this is a small study done again in Japan in 2007. And they instructed men to walk in the elderly men, in the evening or night rapidly for 30 minutes every night for 8 weeks. Now, 30 of the 47 men they recruited actually kept up this walking exercise. And you can see that the number of episodes of nocturia decreased significantly from 3.3 to 1.9. So that's 1.5 episodes a night. So that's really very good. They also looked at the edema ratio, which they could work out, and they found that, as my hypothesis was suggesting, that a lot of these normal older people who are capable, perfectly capable of doing this exercise regime, do have some edema which is not recognized. In this study, they asked 56 patients to modify their lifestyle to improve nocturia, and that consisted of a bundle of maneuvers, restricting fluid intake in the evenings, don't try to sleep in bed for 12 hours and then complain that you had to get up once. Everybody would have to take moderately daily exercise and keep warm in bed. I'm not really sure about the keep warm in bed, but if you're cold in bed, yeah, that's miserable. You'd get up and find some more blankets, wouldn't you? And then you'd sleep better, so therefore you wouldn't get up. And the results of this study showed again a fall in 1 episode of nocturia. And this was in a significant group of patients. This is a randomized controlled trial comparing alpha blockers with behavior and exercise. And so again, they gave a group of interventions to one of the groups in the study. This included pelvic floor muscle training, urge suppression techniques, delayed voiding, fluid management, sleep hygiene, and peripheral edema management, meaning exercise. And then they compared that against alpha blockers. So what they found was that after 12 weeks, the group that had the group of what you would call behavioral therapies reduced their nocturia episodes by almost 1.5, alpha blockers only by just over 1/2. And for some reason or other, the combination, which you thought might have been the best, wasn't actually the best. So behavioral therapy in men, alone or combined with alpha blocker, consistently showed large and statistically significant nocturia reductions and favorable effects on sleep and quality of life. So you can see I am interfering a bit with the next talks because I'm wondering whether we need to reconsider the way that we do nocturia research. One of the other problems is that, of course, the one drug that we could turn to in nocturia is desmopressin. And this is a large study from the States looking at over 4,000 participants, over 50, who were getting up 2 or more times at night, and looking to see whether they had contraindications to taking desmopressin. The mean age was 66, and you will see here 50% had contraindications to taking desmopressin. And in the older age, which is of course the age we're usually looking after, if it was in over 80s, then 73% had contraindications. So the irony is that even though we've got a drug which is effective, then it's often not safe in the elderly person. So I want to finish. I said at the beginning that as I and my friends get older, then nocturia has become more important in our lives. And this is a good friend of mine who lives in the UK. He is very fit for his age. And when he contacted me, he was waiting for a knee replacement and walking had become difficult. And he emailed me and said, I went to see my GP because I was getting up 2 to 4 times at night. The GP gave him mirabegron and escalated the dose when 25 milligrams didn't work. He asked me, Bill asked me, do you know anything about mirabegron? I replied, of course, the first question we ask is, I didn't want to put words into his mouth, so I didn't say, do you have urgency? I said, do you have daytime symptoms? And also, is your blood pressure okay? Otherwise, mirabegron is a safe drug. He replied, no daytime problems, and I don't have urgency. So that's why I doubled the dose. But of course, this is one of the problems. He was given the wrong treatment. So if he'd been in an OAB trial, it would have failed. It would have made the OAB drug look worse because he didn't have OAB. So I then said, will you make a bladder diary yourself? So he's a bright guy and he did that. So here you can say that he's got 2 days of a bladder diary. Here are the times, 1 in the morning to 7 in the morning. Here are the voids. So he voided 5 times. He did his average flow rate. So average flow rate of 10 equates to a maximum flow of about 20. So it doesn't sound as if he's obstructed. So he produced 1,650 mLs at night that day. During the daytime of the same day, he produced only 600 ml. The following day, he produced 900 mLs during the night and only 520. So quite clearly, my friend Bill has nocturnal polyuria. I said, Bill, as you're now less active because you can't walk properly, you are probably pooling fluid in your legs. That's peripheral edema. So what you can do, it's up to you, but what you can do is you can wear elastic stockings which squeeze the legs and help prevent the edema. You can use your exercise bike because that's not going to be as bad on your knees. This will maintain your muscle mass and will shift the water out of your legs using the muscle pump that we all use. If you go swimming, that also works very well for peripheral edema. So those of you who have taught your children to swim will have noticed that when you come out of the swimming pool, you suddenly realize you need to pass urine. You think, oh, I didn't drink that much. That's because even you have had some extra fluid in your legs that the hydrostatic pressure in the swimming pool pushes out. So I also said, Bill, when you're sitting, you have to have your legs up high with your ankles at the same height as your heart. Bill replied a few days later, I've been walking around the village every day. I'm doing regular exercise on my bike. After lunch, rather than sit, I put my legs right up. And in the evening, if I'm watching telly, I also put my legs right up. He then wrote again in 5 days, just wanted to let you know I'm only getting up once at night and have slept all the way through twice. I cannot thank you enough, Paul. Cured in 2 weeks without drugs. So this is to emphasize how important conservative means are, largely through lifestyle changes. So I think we need to rethink our approach to management, get the diagnosis right, use a questionnaire that talks about bother. Is it the patient's main problem? And is it a urological problem? If it's not a urological problem, if you've no reason, no evidence to say it's a urological problem, that essentially means overactive bladder. If they've no urgency, it's not due to overactive bladder. If they might have obstruction or might have detrusor underactivity, then pursue that. If you think it's not, then you can certainly have the assumption that it's peripheral edema, which is a lot more common than anybody recognizes. And you can suggest behavioral modifications, but of course, find out what the person is willing to do. So holistic management is the key and should be used at the beginning in all cases of nocturia. Fluid and food advice, empty your bladder before you go to bed, exercise, weight loss, leg elevation, and elastic stocking. But if you think it's serious cardiac failure or obstructive sleep apnea, you must refer the patient. Now, the EAU say thorough history, that's always a good idea. Nocturia specific questionnaires are sensitive to symptom change. A bladder diary is essential for diagnosis. And a nocturnal only bladder diary really is a bit of a waste of time. So the recommendations are strong for a history, rather weak for a validated nocturia questionnaire, strong for a bladder diary, weak for a nocturnal only bladder diary, and strong for lifestyle advice, etc. So in conclusion, nocturia is highly prevalent, even in young people, at least 20% times 1 at the age of 20 to 30. Nocturia and its associated sleep disruptions have a wide-ranging negative consequence. Nocturia is often an independent entity, but usually, I would say, is associated with other conditions. Many men, particularly, are treated for nocturia unsuccessfully because it's assumed in men that it's secondary to prostatic obstruction. That assumption, of course, would not be made in women. Many men and women have nocturnal polyuria, and there, in this case, nocturia is not a lower urinary tract symptom. So nocturia needs to be properly evaluated and treated, in addition, of course, to the other bothersome LUTs if the patient has other conditions such as OAB. So let's not forget that obstructive sleep apnea is dangerous. This is Mr. Warby, and it was said in court that Mr. Warby had been diagnosed with obstructive sleep apnea in late 2015, and he experienced a micro sleep before the crash. In other words, he fell asleep at the wheel while he was driving a lorry. The jury convicted him of causing death by dangerous driving because he knew he had obstructive sleep apnea, and in Britain, you cannot drive if you know that you have obstructive sleep apnea. You have to go and get treated. So this is a very dangerous condition. So thank you very much for your attention, and I look forward to the other presentations and, of course, to the discussion at the end. Thank you.
Thank you very much, Professor Abrams. And as expected, we expected that you would give a very thorough presentation and we wouldn't need any other lectures or presentations. And that's what has been borne out by your presentation. So thank you very much. I'm sure there are a lot of questions and several questions have been coming up into the chat box, and we will take all those questions during the course of the panel and the faculty interaction at the end. So I'm straight away going to invite Dr. Pavan Vasudeva to initiate the panel discussion, which is based on cases as well as issues. Pavan, all yours. Pavan, as your mic is mute, and I would welcome all the rest of the faculty into this session now. Dr. Anita Patel, Dr. Vijay Madhuri, Dr. Rishi Nayar. I'm not sure whether Dr. Ganesh is there. Professor Ganesh, are you there with us?
Yes, I have joined.
Oh, great, great. Just in time. Perfect, perfect. So we have all our faculty there. Welcome to the program. Pavan, go ahead.
Yeah, so am I audible?
Yes, you are.
Yes. So we'll straight away start with the cases. We have 3 cases and we hope to finish all of them. So the first case, what's happened to my, yes. So this was a 65-year-old male whose main complaint is nocturia 2 to 3 times at night. He's tried lifestyle changes which have not helped. He has mild obstructive lower tract symptoms, no irritative symptoms, no day frequency, no urgency. The IPSS is 8, and there are no other significant medical or surgical history which would contribute. The general physical examination is essentially normal. The blood pressure is normal. There is no peripheral edema. The BMI is normal, and the per abdomen DRE and the FNE as well are normal. He's been taking tamsulosin 0.4 milligram, which was prescribed by his general practitioner for many years now. But recently, for the past 6 months, his nocturia has been bothering him quite a bit. So how would you want to evaluate this patient? Dr. Ganesh, would you want to take this?
Thank you, Pavan, and good evening to everybody on the panel and to the audience. Paul, last time we met, you talked about the cricket. I hope you're not going to talk about it again now. Well, getting back to this case, Pavan, the first thing I'd like to do is to get a voiding diary on him. a 3-day or 2-day voiding diary on him to have an idea as to what is happening. The other thing is, in the last 6 months, lots of things have happened in this world, and what's struck everybody is the corona. And we are seeing lots of symptoms, and patients are extremely anxious about many things that have happened. This guy might be a businessman. You're saying lifestyle changes have not helped him, but there must be something which is bothering him quite a lot, because it's happened very recently. So I would like to go back into his history and really probe the matter quite a lot before I give him anything more. So I need to have a voiding diary and a very good history from this guy. Sit him down, probably his wife and everything else, and find out. He's a businessman. Find out what's happened to his business. Have there been any changes in his sleep patterns, etc.
Okay. Dr. Rita, would you want anything else besides the voiding diary?
Yes, some very simple routine tests, Dr. Pavan. So it would be nice to know, why has he been put on tamsulosin? Because if at all nocturia is the symptom which has bothered him, and he's been on alpha blockers for a very long time. So I would like to look into that also. That would mean it would be nice to have a baseline flowmetry post-void residual, in addition to, of course, the bladder diary and the evaluation for stress level. And I would also want a simple urine report, just to confirm that there is no infection in his urine. And that will also tell me that he's not recently become diabetic, because a urine sugar being absent will tell me a lot. So these are very simple additional tests I would want.
Right, ma'am. So this is the voiding diary, and I've just made a small interpretation so that we can. So the output is about 1900. The day volumes are 12, around 1300, and the NPI is 32%, with the maximum voided volume being 240. Then subsequent to this, we got an ultrasound done where the pre-void was 400, post-void was 200, and the prostate was 50 cc. This is his uroflowmetry with a maximum flow rate of 11.8 and an average of 4.7. And these are his other routine tests, which are all fairly normal. So, Professor Abrams, how would you rate alpha blockers from specifically the nocturia portion? Do you think alpha blockers are effective for nocturia?
Well, I think it's a very nicely investigated case, and it illustrates that actually alpha blockers aren't very good for getting rid of nocturia. And of course, when you look at the change in post-void residual after alpha blocker therapy, it's nowhere near as good as a TURP. So, I mean, this man, as you're implying, has either got obstruction or he's got detrusor underactivity from his flow curve. And he's got a residual urine of 200, and messing around with drugs is not going to be probably a great way to improve his nocturia, which is bothersome. So I would go for urodynamics in his case and work out what the cause is. If it's obstruction, I'd offer him a TURP. And if it's detrusor underactivity without obstruction, I would say, well, your choice is to put up with your nocturia or to use intermittent catheterization.
So within the alpha blockers, is there any preference that you have if the patient has nocturia within the alpha blockers?
I mean, I think I would always try alpha blockers because they're safe and they're cheap. And some patients do get a good result. So when I say they're not very good, I'm using that. If you take 100 patients in this situation with nocturia and you give them alpha blockers, not many are going to do well, but a few will do well. So as it's an inexpensive drug, try it. But he's already been tried on alpha blockers and it hasn't worked. So it's pointless trying it on him.
So I'm just compiling. So the literature also says the same thing, that we may believe that alpha blockers work well, but in nocturia, if you look at the placebo, it's the decrease in the mean number of nocturia is 0.61, and there's just an addition of 0.1 if you add an alpha blocker. There was a paper which said silodosin did better than tamsulosin, and it was found to be significantly better. But there is no clear-cut guideline that one alpha blocker should be preferred over the other in Nocturia. Dr. Rishi, would you consider to add on a 5 alpha reductase in him? Do you think these are effective?
Just going by the prostate volume, yes, he would merit a 5 alpha reductase inhibitor.
So from a Nocturia standpoint.
Yeah. So Nocturia per se is not, see, these are this is going to have a slow effect on the prostate per se, and it's not in this particular patient, it does seem to be having an underactive component in the bladder, and that may be probably secondary to the obstruction. So trying that out may be useful, but it's going to have a slow effect in my perspective, and ultimately he may not benefit too much out of that. You see, his bother score was very low compared to the problem that you have shown. He had a very high post-void residual urine, and his uroflow was also significantly obstructed, though he was not bothered about that. So he might have gradually worsened from a primary case of benign prostatic obstruction to now underactive bladder and having nocturia as the primary symptom.
Okay, so like Dr. Rishi said, so dutasteride has been shown to be better than placebo, but again, the effect is not much. Combination therapy again has been shown to be better than either drug alone from a nocturia standpoint, but again, the difference is may not be clinically relevant, and so that's where the EAU guidelines come in, and they say that there is a weak recommendation for using these drugs from a nocturia standpoint, and the level of evidence is also not that robust. So for whatever it could help, we shifted him from tamsulosin to silodosin and dutasteride. Again, reviewed at 3 weeks. Nothing happened like we all would expect. So what next? Dr. Dinesh, would you want to take this? What would you want to do with him now?
Well, his post-void residue was 200.
Yes, sir.
I would confirm that before I did anything. I wouldn't just take it at 1. I'd probably do 1 or 2 and make sure it is high residue. And I would go with Paul here at the moment, that I think his nocturia could be on balance related to his high post-void residue. And if I have to do any surgery for him, I would do urodynamics.
So, Dr. Nita, do you think TUR has a role in such a situation where so the indication would here actually be only nocturia because he hardly has any obstructive LUTs? Would you agree? And how much do you think TURP makes a difference, or how effective it is from a nocturia standpoint?
So Pavan, if we assume that his nocturia is related to his residual urine, and if the cause of his residual urine is due to obstruction, then indirectly a TURP is going to help him. But in any other scenario, I don't see how it will help him.
Okay, so I'll just share. So these are the studies which have shown that that TURP does help nocturia, and by about decreasing by about 1 point. But like Professor Abraham said, this is the most resistant symptom, and everything else may improve. But TURP would make the least impact on nocturia, and this has been shown in multiple studies. So the proposed mechanism is that it reduces the post void, so it increases the time for the bladder to fill, and by decreasing the obstruction in the detrusor overactivity goes down. There has been a trial which has shown that it is superior to alpha blocker therapy, and for most of the domains. So would you want to confirm or document obstruction before surgery if you're considering surgery in such a situation? Professor Brahms?
Yeah, I mean, I think I wouldn't allow you to do a TURP on me until you had proved that I had obstruction. Whether I had nocturia or not as my worst symptom.
So there are a lot of people who would do a TUR in a normal obstructive LUTS scenario, but here the indication which is evolving for TUR is nocturia. So would you be more forceful, or would you think urodynamic is even more appropriate in the situation?
I'm not hearing you very clearly, but if you're contemplating surgery, then I would do urodynamics.
Okay.
Pawan, if I could interrupt just for a moment. Professor Abrams, purely from a philosophical perspective, ordinarily we don't go down the road of aggressive management for outlet obstruction in a patient who presents with symptoms which are not, who doesn't complain of problems related to voiding difficulty. So how would you counsel such patients in terms of, if they don't really complain of much difficulty in voiding, but their primary symptom is nocturia, that you want to go down this path of doing invasive testing and surgery for this kind of a patient?
Are you asking me, Sanjay? Anita, can you translate for me, please?
No, so Sanjay has asked that in India, we don't routinely do pressure flow study prior to a TURP, more so if the presenting symptom is nocturia. How would you justify that to a patient when his
well,
symptom?
Yeah, no, I think it's a good question. I think I don't think you need to justify urodynamics to a patient. You need to justify to the patient why you don't do urodynamics.
So in fact, my question...
Okay, so that's the other way round. But particularly in nocturia, where we know that it's difficult to make the diagnosis of the cause. And if nocturia is the main problem without particular voiding symptoms, so we've just done a sub-analysis of the upstream study, and actually a high level of voiding symptoms plus a low flow rate gives a very good indication for a good outcome from TURP without urodynamics. But if he hasn't got voiding symptoms and just got a low flow and nocturia, then I would always do it. I think the other point, Ganesh, about that you were mentioning is that the peripheral edema, assessing peripheral edema is usually no use in the clinic. What you should be going is going to the man's house at 10 o'clock at night and doing a proper examination. Because if he comes to your clinic in the morning, he's got rid of his peripheral edema. So, I suggest probably it's not practical for you to go round to the man's house at 10 o'clock at night. So we miss the edema because, and remembering also that you need about 1 liter in the legs before it's clinically detectable. So this is not edema in the way we were taught about edema as students. This is barely clinically detectable, but it's still 500 to 1,000 mLs in the legs. And that's enough to give you nocturia times 2 or 3. So making a proper diagnosis prior to surgery, I think, remains vital.
So, this is a paper from Professor Abrams only, which showed over a 13-year period that if you would have done TUR for a detrusor underactivity patient, the nocturia does not improve. And if you look at patients who underwent TUR versus who did not undergo TUR, the patients who did not undergo TUR actually fared better. So again, it's important that at least in this situation, we should, where this is a doubt, we should be sure. And so this was his pressure flow study, where which showed a bladder outlet index of 50, which is obstructed. And so with this report, Dr. Vijay, would you agree that he would merit a TUR?
Again, like the discussion has proceeded, it does seem likely that the nocturia is due to prostatic enlargement, and he is definitely obstructed, but this merits discussion with the patient because as such he doesn't complain of any voiding LUTS. So I would definitely offer him the therapy. I'll explain the pros and cons, and definitely there are risks associated with surgery as well. So
would you be convinced now to do a TUR in him?
Sorry, asking me, Pawan?
Yes, sir. Yes, sir. Sir, would you
be now? I would tell him as to why I think he should have surgery for his outlet. He's obstructed, and I'll tell him that it's likely that your residual urine will come down, and that indirectly will help your nocturia. And although you may have not much of symptoms, and we know that patients who do have genuine bladder outlet obstruction, not many of them or not all of them complain of obstructive voiding. They just have this because this is the thing that's actually worrying him. And so I would offer him a outlet surgery.
Okay, so this is what happened, that he underwent. Yes, ma'am.
May I ask a question after you complete this, of course?
Yes, ma'am. So this is what happened, that he underwent a procedure. The post procedure, the post-void decreased to 60 cc. His nocturia decreased by 1 per night, and the first uninterrupted sleep period, which was about 2 hours, increased to about 3.5 hours, and his quality of life improved. So there is one question that I would want to put to Professor Abrams, that when we understand that the evidence for TOR is lower in the Nocturia algorithm, would you have considered desmopressin for this patient upfront?
Well, he's on the borderline of risk, isn't he? If he's 65 and he has no heart problems, then you could try him on desmopressin with measuring serum sodium, etc. Can I go back to, I mean, your post-procedure data is interesting, isn't it? Because he's still got a post-void residual of 60. So I'm sure if we look at his contractility index, that comes out at less than 100. So the reason he's not emptying is that whilst he has some obstruction, he also has some detrusor underactivity. And that's why he doesn't empty his bladder completely, because I would expect after I'd done a TURP, the person would empty their bladder properly, and I assume you would say the same after a green light laser. So that's a perfectly reasonable outcome. The alternative, of course, in a man like this is to say to the man, how would you feel about popping a catheter in before you went to bed? Just before you went to bed. Okay. Because he had no daytime symptoms. And some people in the UK would say, well, yeah, I wouldn't mind trying that. I'd like to avoid surgery. I'll do that. And of course, he would have done well. He would have done well from having a catheter put in, him putting a catheter in just before he went to bed.
So if the same case had this urodynamics, you would have counseled him for intermittent catheterization? If there was no obstruction, would you counsel him for intermittent catheterization?
I would suggest him that he put a catheter in last thing at night, if that was his main problem.
Okay, so and that would be only before sleeping, or would you ask him to do it the whole day through?
Just the last bit, Pawan.
So would it be only one time at night, or would you shift him to intermittent catheterization?
Just at night. If there's no other symptoms, just at night.
Okay. Ma'am, you wanted to ask something?
Yeah, in fact, it's interesting you should put up this urodynamics, because in the chat box, there is a question regarding use of bethanechol. And let's just assume that this gentleman is not obstructed, but in fact, he has underactive detrusor. How many of us in the panel would, recommend using bethanechol? This is an open question to everybody. Does anybody use it? And if so, at what dose and how much is the literature proof? Because pharma industry keeps on bombarding us saying that you need to use bethanechol. But are people really using it in practice for somebody with this situation, substantial residual urine, but a urodynamic proof of having underactive detrusor? Do you use it, Pawan?
So I use it only to convince the patient that it's not going to work, because, just as a bridge, but I don't use it thinking that it's going to work.
What is everybody else's opinion? I'm just curious.
Pawan, I know that a lot of urologists use this drug. A lot of urologists use it in spite of whatever is written. Personally, I don't use the drug, but I know for a fact I've seen prescriptions from lots of urologists who
I concur
swear by this drug. And as Anita says, the pharma industry comes back, and now recently they've got some new bethanechol. He came touting it the other day, saying it's extended release and all that. But let's go back to the actual genesis of this bethanicol. It was a supra-sensitive test that used to be done many years ago. And that was based on principles of pharmacology, where you denervate a bladder and then it responds to a dose in a very exaggerated manner. And that was not oral. That was a subcutaneous dose that was given of bethanicol chloride along with the urodynamic test, and you showed that there was a rise in the pressure. And that's only for patients who had neurovesical dysfunction. So,
Thank you, Dr. Ganesh.
the whole story of bethanicol is there, and it's not something that we would use on patients who have this so-called weak bladders.
Thanks, Professor Ganesh. We have lots to discuss, Pawan. We'll move on to the next.
Okay, so we'll go down to the second case. So this was a 61-year-old male with nocturia 3 to 4 times at night, and he denies any other history. I'll just go through this I'll just go through the history. So this nocturia significantly affecting his quality of life, does not let him get a good sleep, and he feels fatigued during the day. Now, looking at the other things which could cause polyuria, which is, so he doesn't have any kidney disease, he is non-diabetic, there is nothing to suggest a cardiac disease, non-hypertensive, no postural hypertension. He lives alone and he denies that he snores. There is no relevant neurological history. He has a sedentary lifestyle, not much exercise, and his liquid intake would be about 2 to 3 liters. So I'll go through the examination as well. So his weight was 80. So his BMI is 31.2. He's obese. There was no edema, no varicose veins. The CVS examination was normal. Blood pressure was normal. Professor Abrams, how would you want to evaluate this patient? Am I audible?
Well, of course, a man who lives alone saying that he doesn't snore is completely meaningless. He needs to get a wife and then answer the question. The wife can answer the question.
He could record himself in the night.
But he's got, I mean, he could well have obstructive sleep apnea, couldn't he, with his BMI. And so I think in the absence of anybody being able to give any evidence, you may well need to send him to a respiratory physician to do a sleep test.
Okay. Dr. Rishi, how would you want to evaluate this patient?
Evaluation will proceed on the same lines, although we are getting a direction from the history that his BMI is high and he might be having OSA. So we would need to evaluate him on that lines first before we start any particular kind of a treatment. But yes, simultaneously we would like to do a Euroflow or PVR and his void volumes and the voiding diary would be essential before we proceed further.
Okay, so this is what we got. This was his voiding diary, which showed an input of So it showed an input of 2,100. The day volumes, the output of 1900. The night volumes were 850, and the NPI index was 44%. So which means he does have nocturnal polyuria. This was his ultrasound, which ultrasound PVRU was negligible. The uroflowmetry was normal, and these were his routine tests, where the creatinine was normal, sodium was 137, and he's not a diabetic. So regarding sleep study, Dr. Ganesh, how do you decide whether you would want a sleep study in a patient?
Well, I would, as Paul said, if somebody is there with him to say that he's snoring, I don't also look at whether during the daytime he has micro sleeps. This is something that happens to people who don't sleep well at night, and they do have. He's driving and suddenly he finds that he's got a momentary loss of, something happens, or the car veers to some side, or he's in a shopping mall and he loses something, he forgets where he is at the moment. So that might give us an indirect evidence. He's obese, he's 85 kilograms and he's short. So he's not going to tell you that he's snoring, as Paul says. So I would actually upfront send him to the pulmonologist and see whether he does have problems.
Okay.
You haven't told us whether he's a smoker.
He's not a smoker.
He's not a smoker. Fine. So I would send him with this with this query to the pulmonologist and say, I want to know whether this guy has this problem. Also, his voiding diary shows he's living alone, whether he's having a couple of alcoholic drinks in the evening, which is causing a problem. I don't know that. But he said only tea and water, but whether he's just having just plain water or mixing it, I don't know.
Okay. So, there is a consensus document which was published in 2019, which says that you could use two questionnaires to assess whether these patients are at risk of OSA. One is the Berlin questionnaire, and the other is a fairly simple stop bank questionnaire where which has 8 points, and if he or she fills 3 are positive. So gender would be 1, the age, BMI, and so that it's a fairly simple screening tool, and if and which has fair sensitivity and fair sensitivity for OSA. And so he was falling into the high risk category. We got a sleep study which was normal. Dr. Neeta, in patients with nocturnal polyuria, how do you decide for a formal cardiac evaluation?
So let me put it the other way. If I don't find any obvious urological issue with the patient, and if there is a suggestion that there could be a cardiac issue, I actually get a cardiology colleague rather than me breaking my head over it. This chap is overweight. He denies that he's snoring, but well, you've done the sleep study, which is also normal. I think in the history and examination, there was no pedal edema, was there?
No edema.
No. So I would just, clinically, though from my side, there is no indication, I would want a cardiac evaluation just in case. That's about it.
Okay. So if there is history of exertional dyspnea, orthopnea, and leg edema, that would specially merit a cardiac referral. Professor Abrams, what would be your working diagnosis now for this patient?
Well, if his sleep study was normal, I don't really know enough about sleep studies to know whether their positive predictive value is perfect. Probably nothing is, but certainly I would be amazed if a man of his size, who is largely inactive, I would be amazed if he didn't have peripheral edema in the evening. So we can't rely on the assessment of edema in a urology clinic unless you do evening clinics. And I'm serious about that, because when you have nocturnal polyuria, you clear all the fluid. It takes you 12 hours during the day to reaccumulate the fluid in your legs, which is why, of course, that Chinese study was clever, because they told these old men to go out in the evening and do 30 minutes of fast walking. That was clever. That was the best time of day to do it. So we need to look at these patients in a different way.
So if you were to at this stage, you would offer him some lifestyle, or would you be considering desmopressin at this stage?
Telling him to go out for a walk every late afternoon. It's easy to go out for a walk in England because it's cold, so you don't get too hot. But going out for a walk in India, especially if you're obese, I should think even in the evening, you get very hot and sweaty. So many patients maybe wouldn't like to do that. I don't know. You'd have to say whether that's practical.
Okay. So Dr. Vijay, what would you advise this patient?
I start off with lifestyle modification. I think weight loss is one of the first things which you need to do, and add some exercise, especially at the evening time. And then let's reassess again after 2 or 3 weeks and see how he fares.
Okay. So basically it's lifestyle changes and desmopressin, or lifestyle changes followed by desmopressin. So Dr. Ganesh, what lifestyle changes do you think work for nocturia? Professor Abrams has already gone through them, so I'll just run through them for the time is a little short. So modification of fluid intake, salt intake, protein intake, modification of calorie intake, physical activity is extremely important, and sleep hygiene or good sleeping habits should be explained to this patient. So Dr. Ganesh, what what are the factors which impact your decision whether you would initiate desmopressin or no? So is it the frequency or the level of bother?
I think it's the level of bother that I'm concerned about, because I'm going to use a drug which is potentially dangerous in some of these patients, and therefore I want to be very certain that he's going to be affected, and I have to tell him that these are all the side effects that I'm concerned about. I need to check his sodiums, etc., because these patients you may not see them, but they may land up in the emergency room in some other hospital in the night with this problem, with loss of consciousness and disorientation. And the person seeing them in the ER may not have access to his drug chart to know that he's got desmopressin, he's on desmopressin. So I think it's a very, very serious commitment on the part of the urologist to actually start him on desmopressin, and that's the message. And I would like to do a sodium immediately. I'd like to do a sodium after 48 hours and later.
We're coming to that. So it's basically the consensus is the level of bother should be the key factor. And Dr. Neeta, does the bladder diary impact your decision?
Yes, Dr. Pavan, because if the bladder diary proves that there is nocturnal polyuria,
okay,
and
so that's
there is frequency, of course it bothers my decision. So bother factor is the subjective bit and the nocturnal polyuria is the objective bit. Yep.
Yes, so there is consensus that unless you demonstrate the presence of nocturnal polyuria, you should not be prescribing desmopressin. And Professor Abraham, do you check
Pavan, if I can just add something there.
Please.
The diary, it's also important to make sure that the patient doesn't have a global polyuria before you add desmopressin. Even if it's not technically global polyuria, if the 24-hour urine volumes are high and you give desmopressin, the patient can get into trouble. So I think that exclusionary value is important. Yeah, go ahead.
Yes. So Professor Abrams, what?
Pavan, can I just add a little bit?
Yeah, please.
So if we are having only nocturia as a symptom in a patient, then what we are looking at is possibly only pedal edema and nocturnal excretion of that excess fluid. I would generally prefer not to start any treatment unless I have had a cardiac and a respiratory evaluation in such patient.
Yes. Yes, so that was covered in him, the sleep study. I mean, that evaluation was covered.
Because there is always a chance, because this could be one of the compensatory mechanisms for the cardiac or respiratory function. So I would not like to interfere till such time his cardiac evaluation is properly done.
Okay. So, Professor Abraham, what are the GFR cutoffs and what are the sodium cutoffs that you would stick to before prescribing desmopressin?
Well, I think it's mandatory to do a baseline sodium. Yeah, I mean, we would always do, if we were doing a sodium, we'd do an eGFR as well. But certainly with respect to the last man, I'd be scared to treat him with desmopressin. He's got lots of risk factors with his weight, his inactivity, etc. So, and I also might doubt that he would come for a repeat sodium after 5 days and after a month.
Okay.
So I would be nervous.
Okay, so there is a consensus that you cannot give desmopressin at less than 50 GFR, and if the sodium is less than 130, you should not be prescribing desmopressin. Between 130 and 135, there is some controversy whether you can initiate desmopressin, and the sample can be given at any time. So Professor Abraham, what dose and what formulation do you prefer in men, and what dose in women? Professor Abrams, what dose would you prefer in men?
Well, quite honestly, I almost never prescribe desmopressin.
Okay.
Because I think it's too difficult to manage. And the reason I say that, well, firstly, I think you can find other ways to treat these patients.
Okay.
They're usually elderly, so most of them, as that study I showed you at the very end, at least 2/3 of people have contraindications. Now, within the UK system, the patient is not going to keep coming back here for serum sodium. So I've got to rely on the GP for doing the serum sodiums.
Okay.
And so that, again, introduces an element of risk in the older patient. So okay. I wouldn't use it. If I was forced to use it, I would use as low a dose as possible. And I think the new melt is probably, because of the lower dosage, is a good one to use.
So this man was started on 60 micrograms of the desmopressin melt. And Dr. Anita, would you call all of these patients for follow-up sodium checking, or is it risk-based?
No.
And how often would you do it?
Anybody who I start on desmopressin must have a pre-desmopressin sodium level. And the first level I check after about a week. And let's assume that is fine. I call them after about a month. And the dose I prefer, as you mentioned, is the new melt preparation, 60 microgram. Okay. I check sodium in everybody.
Okay. So there was some, so people believe that younger people you could exclude, but yes, majority of the people would require follow-up for sodium checking. And the like ma'am said, it should be once in the first week and then at 1 month. And Dr. Ganesh, at what desmopressin, at what sodium levels would you think of withdrawing desmopressin?
I wouldn't go only on the sodium level. I'll go on a clinical hunch. Even if this guy has got some headache, if he's not feeling too well, I think these are red flags, and I wouldn't actually rely on that. I would do a sodium at that point, and okay. I would rely more on what his symptoms are when he's started on this drug. So I'd warn him. And anything less than 130, I think I would be very wary.
Okay, okay. And Dr. Rishi, how common do you see hyponatremia in patients you prescribe desmopressin to?
I have not used this drug as so often to be talking in terms of percentages, but if you go by literature, maybe yes, 5%, 5 to 10% would be at risk of developing.
Okay, so data has basically shown that for men less than 65 years, it's fairly safe in the doses that we use, and but once more than 65, then it's a real issue. And so there are some contraindications to desmopressin, which I will skip because of time. And so this patient reported symptomatic improvement by 1 episode per night, and he was fairly satisfied with the dose he received. So, Professor Abrams, how much improvement as a clinician do you target? So, is it the patient's subjective improvement, or do you have any objective targets when you treat Nocturia?
No, I would entirely go on the patient's statement as whether they were satisfied. I think if you didn't think it was enough and you put the dose of desmopressin up, the patient became sick, and they had said they were satisfied, then you'd be in a lot of trouble. So I think satisfaction here is really important.
Dr. Anita, would you have any objective targets?
Not really, but if I must put a figure, at least 50% reduction in his nighttime urine production, if I'm going to measure that. And I usually ask them to give me a 1-day record of their urine production, about a month when they come for a follow-up. But of course, his bother factor, not getting any side effects and clinically getting better, is my yardstick.
Okay, so there are, so people say that there are two things that, so one is that you should get 7 hours of sleep, and less than 7 hours of sleep is associated with adverse health outcomes. So people use this as a yardstick. And also what Professor Abrams had mentioned in his lecture, that there is, it is these first 3 hours which are important, because it is during these 3 hours that the N3 sleep, which is this dark green, is mostly concentrated. And as you move, as the number of hours increase, the frequency or the amount of this N3 sleep actually goes down in this section. So if you can provide them with these 3-4 hours, then so people use this as a surrogate for quality of sleep. So we have less time, so I'll just move on to the next case. So this was a 66-year-old female who essentially had wet OAB. She had frequency, daytime, nighttime, urgency, urge incontinence for 2 years. She is significantly bothered. She complains of mild snoring, which is vouched for by her husband, and otherwise there is nothing. Her BMI is 22. Blood pressure is normal. Dr. Ganesh, how would you want to Dr. Dinesh?
Well, again, I think apart from the usual good physical examination, I would also, in spite of the fact that you said there's no vaginal discharge, I would do a vaginal examination. A pelvic exam, you said, is normal, but I would certainly look for evidence of postmenopausal changes there. And certainly, to start off with, I would do a voiding diary and check her residual urine volumes and things like that we have just discussed.
Okay. So
these are
this
the
was
first thing that I would do.
So this was her voiding diary. The total input was 2,250. Output is 2,290. The night volumes was 800, which is again falling in the zone of more than 33%. Her NPI was 34.9. Her ultrasound was normal, post-void negligible, uroflowmetry normal, and so was the urine analysis. So, Dr. Vijay, what would be your working diagnosis for this patient?
So she has overactive bladder definitely, so that's there, and there is nocturnal polyuria, so that's contributing to the nocturia in this patient.
Okay, so Dr. Rishi, how would you want to treat this patient?
Well, in this particular patient, the bother would be more because of the incontinence, I would assume. We need to talk to that with the patient, what is she most bothered about, and I assume that it would be because of the incontinence during the daytime. If she is having nocturnal incontinence also, maybe we are looking at severe overactive bladder, and she, can you go back to the total voided volume, how much was it? So, okay, so she is about 2,200 a day. So I would treat her on the lines of wet OAB.
Wet OAB.
First, before specifically introducing any treatment for nocturnal polyuria.
Okay, so that was what was done. Conservative measures were explained from so patient education, bladder training, pelvic muscle floor therapy. She was counseled regarding her fluid intake and fluid restriction, caffeine, alcohol, and lifestyle changes, which were suggested by Professor Abrams, were also implemented. So she was called back at 12 weeks, and the day frequency had decreased to about 7. She was better able to handle her urgency, though she was still wet OAB, and nocturia, not much had changed. So, Professor Abrams, how would you want to take this further?
The other thing we haven't discussed is water-containing food. So an Indian diet is basically very healthy, in my view, but it includes a lot of water. So if she's having an evening meal, and she's also, I noticed, having a cup of tea just before she goes to bed, I would say she could play around with her liquid and food intake so that she reduces the amount of water that she's ingesting.
So her wet OAB component improved with the conservative management. Would you want to? Would you consider adding antimuscarinic in her?
Yes, I would. No, I would certainly. I would certainly offer that once she'd done the lifestyle interventions. I think the lifestyle interventions are really important. And when you look at the bladder diary, you can add a food component to that if you want, and then you need to discuss with the patient about their water intake in general. And as I say, in Indian diets, I think that's even more important. English people don't eat nearly such a good diet as you do in India. So you get a lot more water. And as I say, getting them to adjust that will give you just as much improvement as putting them on an antimuscarinic. So I would always do that first.
Okay. So we added solifericin 5 milligram to this patient. And what happened? So 6 weeks later, we reviewed her. So her OAB was well controlled by now, but her nocturia was persisting. So, ma'am, Dr. Nita, how do you think OAB medication impact nocturia, or how helpful are they in nocturia?
So they are helpful, provided the diagnosis is correct and all the lifestyle and everything has been adhered to. So if she hasn't really responded, this is the point where I would want to check her compliance with everything. And I would also want a repeat bladder diary, because it's very surprising that for a lady consuming 2.2 liters in the day, if she's reduced that, lifestyle is changed, pelvic floor is better, why is her nocturia selectively not getting better? Is she sleeping well? Is the additional question I would ask her. I would want to read that diary.
Okay. Dr. Ganesh, how do you think is the impact of OAV medications on nocturia?
Well, I think it does sort of improve the bladder volume, and thereby maybe she might not wake up at night. Additionally, this particular lady, husband says she snores, and if it doesn't improve with these lifestyle changes and the drugs that you're using, I would suggest that they actually look at obstructive sleep apnea if she's the one who's snoring.
Okay, so the EAU actually says that antimuscarinic medications, while they will reduce the urgency which is associated with nocturia, they hardly impact the number of episodes. So even in alpha blockers, we are still getting a 0.01 or 0.02, but surprisingly, antimuscarinics are only addressing the urgency that is associated with nocturia. Professor Abraham, what would you consider next? Would you think Botox? So she now has residual nocturnal polyuria. Would you think Botox is appropriate? Would you think desmopressin or a sleep study or anything else?
What is her level of bother?
She's bothered, fairly bothered.
By the night time more than the daytime?
So the day has resolved, but she's now looking forward to the night voids decreasing.
Well, and I mean, I think Anita's point about compliance with the lifestyle interventions, I think it's fair to say that most people are not very good at complying to the lifestyle interventions.
Okay.
And then it becomes an issue of, well, you're not going to withhold drugs, are you? Because people find it difficult to take exercise every night and et cetera, et cetera. But then going on to other treatments like botulinum toxin or sacral nerve stimulation, I mean, then you're raising the level, you're raising the bar very high. So I would be really pursuing the simple treatment still.
So how is your do you have a low threshold for a sleep study in nocturnal polyuria?
The threshold for what?
A low threshold for sleep study in nocturnal polyuria?
Her nocturnal polyuria, well, you haven't shown us a bladder diary after she's done after all the interventions.
Okay.
Has she still got nocturnal polyuria now? It's not a severe one, not like the man I showed you.
Okay. So I'll just go through what actually happened with her, because we've already run. So yes, just finishing 2 minutes. So a sleep study was done and we found moderate OSA in her. CPAP was instituted at 6 weeks. She's asymptomatic, does not get up at night any longer, and she continues to be on solifenacin. Now I looked up, is OSA common in the non-obese patients? And this is what I found, that 1 in 4 of those who are documented with OSA are actually have normal BMIs, and 50% would still not fall into the obese category. They would be overweight, but not obese. So a non-obese is not it's not that we should not think about OSA in patients who are not obese. Thank you.
So, can I add a point here?
Yes.
So, in such a patient, before we consider doing a Botox, even though the history is suggestive of overactive bladder per se, we must not lose sight just because she is a female that she may not be having a bladder outlet obstruction as a cause of all these symptoms.
So the Euroflow
so doing a Euroflow and a PVR estimation.
It was done at the beginning. Yeah.
Okay.
That was done. Yes.
Pawan, may I make a comment, or are we really short of time? I'll wait.
No, ma'am, please, ma'am.
Yeah, so as a urologist, before a sleep study in a patient who is not yet happy with the outcome, at that point, I would want to do a urodynamics. That was not there anywhere in your evaluation before I go ahead with a sleep study. That's the only point. I'm not discussing what it would show and all that, but I think that is what I would definitely do.
So if the diary, if you had got a repeat diary done and the repeat diary had shown nocturnal polyuria, you would still have wanted to do because the flows are normal.
I wouldn't have. Then I wouldn't have, because during the daytime, she definitely showed improvement in urgency. But as we don't have a bladder diary, there is nothing to prove that her volumes were better. So that's the only point. Otherwise, I agree with everything. Yeah.
Thank you.
Certainly the points you made about the obstructive sleep apnea people don't have to be high BMI to have obstructive sleep apnea. Some people with obstructive sleep apnea do not have nocturnal polyuria. We have a friend who's early 70s, and she has obstructive sleep apnea cured by the mask, and she doesn't get up at night. She never got up at night. So there isn't a single pattern. But if presenting to us, we would expect them to have the bad snoring, and she only had mild snoring. So we would expect the partner to be able to say, the husband to be able to say, well, yes, she stops breathing. And also the other key symptom is the tiredness during the day. And if somebody's a driver, they will often tell you, well, if I get in a traffic jam, I realize I've fallen asleep because the car behind me starts honking their horn to wake me up. And then, that's obstructive sleep apnea, where for the average person who has to get up at night, they don't have that degree of tiredness. So I think your lady is slightly unusual, but it's great that you cured her. Or, well, the respiratory physicians cured her. You cured her because you sent her.
Thank you, Pawan, for some great discussion. Now, can I ask Sujit? Sujit, you are our senior residence representative. Would you like to ask any questions from the faculty?
Thank you, sir. Thank you for giving me this wonderful opportunity. I thank each and everyone in the name of all residents all over the India for providing us with a great opportunity to learn more about Nocturia. So I have one doubt regarding the research aspect of this Nocturia and bladder diary. When we have a 3-day bladder diary of a patient, and while analyzing, if we found nocturnal polyuria index high in day 1 and day 3, and there is no nocturnal polyuria in day 2, and how we will take this data, how can we analyze why we take this data for a study purpose?
Professor Abrams.
Well, yes, you do need 3 days, because when you're used to looking at bladder diaries, you will see big differences. So if you did a bladder diary on me, and I had 2 days of exercise, which usually I will walk for 1 or 2 hours, and then I had 1 day where I didn't have anything, I'd have nocturnal polyuria on the night after I'd done no exercise, and I wouldn't have nocturnal polyuria on the other ones. So you've got to ask about physical activity as well as just what's on the diary. The diary is vital because you have the input as well. And as I've suggested, ask about meals. If you're eating a very high water content evening meal, then you may well be taking in 500 to 1,000 ml of water in the food. So it's very considerable.
So Professor Abrams, Sujit's question is very specific regarding research. Should you take the 1 day which is the most representative for the patient into your analysis in a study, is what his question is, or should you average out the 3 days and use the data as the average of the 3 days?
Well, I think as I believe that most nocturnal polyuria does not have any serious underlying cause. I believe in older people, it's usually due to peripheral edema. The interesting thing then becomes the difference between a good night and a bad night. And usually by taking a good history, you can work out why the person was better one night than they were on the other. So I think you need to look at the bad days and you need to look at the good days so you can compare them.
Okay, we have a few questions from the audience. Now, there's a question by Dr. Ganesh Kamath regarding people who work night shifts. Now, we know if you work a night shift, then your night becomes the day or the time when you sleep. But can you just extrapolate that data? I mean, is it the same as somebody who sleeps in the daytime because he works night? Is that exactly the same?
Nita's going to say something.
Can I answer that, Sanjay, if
Yeah.
you... So I was asked to do some research by a Marathi newspaper about a year ago about the impact of night duty on quality of life, on various aspects. And so I did a little bit of reading on that. And the representative sample was taken as the nurses who work maximally in shift duties. So it's not even a night duty on a particular day alone, because the timings of their duties also change. And the consensus was that it does impact the overall urine production, both during the day and at night, even on the days that they're not doing the night shifts. And the incidence of nocturia, even on the day that they're not at work, is way higher than what it would be for those who are not doing shift duties. So it adversely impacts the nocturia. That's the consensus.
So do their biological rhythms shift precisely to a day-night reversal? I mean, because
No.
they're sleeping in the night.
No.
What happens to
no.
the
So there is no proof.
The ADH secretions, the biological rhythms, do they just precisely shift?
So there is no precise shift. But what they have found is that they continue to have more bothersome night frequency if they are doing shift duties. But the support of that is not in the form of shift in the biological rhythm, but the bother factor is way higher, as it is in their sleep pattern, the acidity pattern, the cardiac events, and of course the secretion of ADH also.
Sure.
But
Ganesh,
yes, there is definite evidence.
Dr.
Yes.
Ganesh.
Can I ask Anita a question on that study that you did?
Yes.
These nurses, were they drinking a lot? Because I find that the nurses do drink a lot of fluid at night when they're on shift duty.
Yeah, Ganesh, I didn't do the study, but I looked up a lot of literature because I was asked to write an article for a newspaper. And in fact, the nurses on duty tend to drink less water because they don't want it to interrupt their duty schedule. And despite that, their nocturia level is higher when they are not on duty. And if you just Google this, you will find support to the statement that I'm making. It's not my own research at all. So
Professor Abraham's final comment to wind this up, and then we'll go to the next question.
No, I don't see. I mean, the good thing about shift workers is they're younger, so they're more adaptable, and it's a good thing that people over 65 don't have to do shift work because their lives would be completely chaotic.
Okay, Dr. Abhishek has a question with regard to estrogen deficiency and nocturia. So what could be the mechanisms behind nocturia in a woman with estrogen deficiency? Any of the faculty who would like to take that up?
One of the possible explanations I can think of is that hot flashes usually lead to disturbance in sleep. And this may lead to reduced quality of sleep and may be associated with nocturia.
Any other faculty would like to chip in?
Yeah, so Sanjay, again, for this, there is some support that with menopause, dropping hormone level, there is a change in melatonin level. And change in melatonin level indirectly affects the sleep pattern. And that is associated with higher incidence of overactive bladder symptoms. And the estrogen level drop is also in some way related to the circadian rhythm of ADH. So yes, there is evidence that the nocturia is higher in menopausal women. Yeah.
Okay. Another question from Dr. Ali Poonawala from Bangalore. Is the additional effort required to prepare a full bladder diary worth it in terms of getting the additional information which you get over and above preparing a frequency volume chart in the evaluation of these patients? Professor Abrahams, you're very passionate about this one, so I'll give it to you.
Yeah, I mean, I think the filling in a bladder diary is enormously beneficial to the patients themselves. And so we're getting more interested in self-care, especially with an aging population. So what we're going to do is to tell people to do their own bladder diaries. But already when you've asked the patient to do a bladder diary, and they always get their bladder diary before they come to see us. So they come in with their bladder diary and their questionnaire completed. And they say, oh, well, it was really interesting doing this bladder diary. Do you think I'm drinking too much? I think I may be drinking too much. So it makes them question their own behavior. So they actually, the intelligent ones, do exactly what we would do with our medical knowledge. They restrict their fluids, they stop drinking too much coffee, they watch what they eat in terms of water, etc. So I think the patient gets a lot out of it. And of course, it sets the baseline for us prior to any further treatment. So we find it's certainly worth the effort. And in terms of nocturia, well, if somebody's going 2 or more times at night and you don't ask them to do a bladder diary, then according to the guidelines, you're a bad doctor, because the guidelines all mandate a bladder diary for nocturia 2 or more times, quite rightly. You can't manage nocturia without a bladder diary. With that, I'm going to say goodbye to you, if that's okay. I can't hear you. You're muted, Sanjay.
Oh, I'm so sorry. Okay, we've got probably what would be the last question of the day, and this is from one faculty to another, from Dr. Rishi Nair. So Rishi, I'll speak on your behalf because you've posted it. Is nocturia without nocturnal polyuria a standalone age-related problem distinct from overactive bladder? So nocturia, no nocturnal polyuria, no urgency. So is it a separate standalone age-related problem, independent and distinct from overactive bladder?
I think that's a very good question. And I'm sure we've got the data in all our urodynamic laboratories, because we've got loads of patients, loads of bladder diaries. We know who's got nocturnal polyuria, we know who's got nocturia without nocturnal polyuria, and we know the urodynamic diagnoses, but I don't know the answer. So there's a good project, a very good project there for some young urologists.
Okay, any last comments by any faculty before I turn this over to Dr. Keshav? Well, so I think we had a take-home slide. Pavan, if you can just project that. So I will quickly run through some of a few take-home messages that we have from today's discussion. Right. So I think it is important, as Pavan has put here, that urologists need to own the symptom of nocturia, even though several patients who have nocturia have non-urological conditions. So it's our responsibility to make sure that these patients get the right care and get referred to the right doctors as required. In the evaluation of these patients, it's absolutely essential, as has been told time and again today, that a bladder diary must be prepared. Without that, you just cannot manage these patients at all. While there is good evidence for the use of desmopressin is the decision to use desmopressin is not a casual one. It carries a lot of responsibility, as Dr. Ganesh said, and you must be very careful in following up these patients if at all you choose to prescribe them. And you can see here from this faculty set here that most of the faculty are in fact quite reluctant to use desmopressin, and it's a last resort management because there is so much responsibility in using it. TURP or prostate surgery is not a natural decision in a male who comes with nocturia. It's not the usual decision. A few select set of patients might benefit from interventions for the bladder outlet, but you need to be very careful before you offer it, especially if the patient doesn't complain of much voiding difficulty. And it's probably better to have urodynamic documentation of bladder outlet obstruction and a documentation of their bladder contractility before you offer surgery. And most such patients would typically have a high post-void residual and a low void percentage. With that, I would now close this discussion. Thank you very much to all the faculty and the delegates who've been with us almost all through, all the delegates. And I had this session back to our Honorary Secretary, Dr. Keshav Murthy from Bangalore. Dr. Keshav, all yours to wind up.
Thank you, Dr. Sanjay. I must thank on behalf of the Urological Society of India, Professor Paul Abrams, for being part of this webinar. I also thank all the national faculty, Dr. Pavan Vasudeva, Dr. Ganesh Gopal Krishnan, Dr. Anita Patel, Dr. Vijay, and Dr. Rishi Nair for being with us. And I thank all the delegates who have attended this. I hope it was a useful discussion for all of you and informative one. Thank you, Sanjay, for hosting this. Thanks a lot.
Thank you very much for an excellent session.
Bye-bye. Thank you.
Bye.
Thank you.